So thank you, Julia, for putting the panel together, and Bernhard for the invitation, along with the other two folks. This is something that I started looking into during residency back in Cleveland when Dan Sessler called me to his office, and he told me, hey, Juan, you've been in MD Anderson. Do you want to do something related to oncology and anesthesia? And I say, what is this guy talking about? And that's when I started, pretty much almost 10 years ago. At the beginning, I made, and I continue made several mistakes. And I'm glad that all the three previous speakers have concluded that cancer is a very complex disease. So if we believe that 2 hours, 3 hours of any anesthetic have any impact, has to be very well studied. So, okay. The green, yep. Okay, there you go. No, there you go. So have no disclosure to make. I hope that everybody reads very careful about this, because people in the past have tried to quote me, and I don't want to influence anybody of you in your care. I have no data to do it. So this is pretty much what you've been shown before, but this is what surgery does. This is very well studied already by our surgical colleagues. So surgery might influence cancer growth directly by promoting inflammation. Most of the tumors, as Bernhard said, love a pro-inflammatory state. Surgery produces immune suppression and a shift from M1 to from Th1 to Th2 response. We might have M2 polarization. Then we haven't talked, and I haven't heard today anyone talking about stem cells in the tumor microenvironment. I think we need to get a little more close attention to this rather than cells per se, because the heterogeneity of the tumor is most likely driven by the stem cells in the tumor microenvironment. Then we know that we promote inflammation and angiogenesis. This has been here today. And then we promote epithelial mesenchymal transition. When the surgeon manipulates the tumor, there is a release of CTCs. Now, not every CTC or circulating tumor cell will attach to the endothelium or will form a metastasis. Only a very small amount, in the order of 1% or lower, will have the ability to seed, attach to the endothelium, and get out then from the blood vessel. And they do that by changing their phenotype. So when we look at CTCs, we have to be sure that the cells do have that profile or phenotype, I would say, to then become potential metastasis. Now, when we look at immune suppression, my lab has shown that it happens pretty much in most major oncological surgeries. Here you have a case for a mastectomy, abdominal surgery, thoracotomies, pre and post a number of NK cells, the percentage, and then the cytotoxicity or natural killer cells. And you see that the function goes down. You see that it's pretty consistent among these three major surgeries. These are large mastectomies. These are mostly colorectal liver resections, metastatic liver resections, and these are thoracotomies. So pretty consistent. So I would say that when you have a belly case or when you have another type of surgery, we should expect this. Now, I have no idea what happens to GBMs, for instance, but is data out there that the function of the natural killer cells peripherally goes down. Now, the other thing is, I do not know whether this has actually an impact on the tumor microenvironment. Data from Donald's Buggy group shows there are some changes in the function or the phenotype of the natural killer cells within the tumor, but I would argue that data, you need to look at that very carefully. Now, what happens if the patients are taking beta blockers? Interesting that we heard that probably modulating the stress response, sympathetic response, we could modify or bring back the function of the immune system. And somehow, in these patients, if we're taking a beta blocker, they had a little bit of a higher function, but I wouldn't consider this clinically relevant. And the other thing, these beta blockers were most likely metoprolol, which is not the one that I would use. You would use probably atenolol. So then when we go into the lidocaine, I got interested because lidocaine is a very cheap intervention. And when Dan Sessler called me to his office, said, Juan, if you're going to try to solve this, has to be cheap and generalizability has to be widespread. Otherwise, it's going to be another intervention that we go nowhere. So we took 3 different types of cells. These are leukemia cells, these are type of lymphoma cells, and this is AML cells. And we exposed the natural killer cells to increasing concentrations of lidocaine. And in our hands and in vitro, we were able to demonstrate that at these concentrations, 1 to 10 micromolar, in the lab, we restored or increased the function of the natural killer cells. So after that, we have PBMCs from a randomized controlled trial, and that we took some extra or leftover samples, I should say, and we exposed the natural killer cells of patients this time with lidocaine. Similar experiment that we did here. What we found is for most tumors, for most patients, we were able to restore, I should say here, the function of the natural killer cells in vitro on the cells that were collected after surgery. So this is the first evidence that we have in my lab on cancer patients. The only group that we couldn't do it is in an orthopedic surgery. I don't know if this is related to the surgery or because we have very few patients. Now, there is data out there in humans that if you compare giving IV lidocaine to epidural lidocaine versus normal saline, the function of the natural killer cells, in fact, is preserved when you give IV lidocaine compared to epi. And this is probably to what we were listening earlier, that when the first phase, I would say, or very early phase of the stress response, natural killer cells will increase the function. But this is within minutes. Afterward, there is a decrease in the function. So here, probably by giving epi in the epidural, lidocaine in the epidural space, we suppress the catecholaminergic or sympathetic response of these patients, and that's why we have suppression. And as I told you, when you give IV, they didn't see this effect. All right, now we go to inflammation. We talk a little bit of immune suppression. There are many other cells that I haven't commented at all. But as Bernhard said, cancer comes with a relatively high pro-inflammatory state that is driven either by their tumor per se or is driven by us as how we live, to put it away. We smoke, we eat bad, we don't exercise. So all these things promote inflammation, and majority of the tumors or the cancer are linked to somehow to inflammation. This is data from my lab. We show that the typical stress or inflammatory response, as you can see here in cortisol and interleukin, as you can find thousands of papers showing the same, but I put it because this is from our group, that after surgery on day 1, you have increase in cortisol and IL-6. Whether these can be modulated, we just published a paper also from my group saying that when you do an epidural, you can modulate, but that in our hands only lasted for 1 day. After the 3rd day, we saw a switch when in IL-6 and pentaxin 3 oncotaxin. So it's not as simple as epidurals will modulate inflammation or had an anti-inflammatory effect that is long-lasting. I would say that perhaps looking depends on the cytokine and it depends on the patient. But our paper, when I was shocked when the statistician told us that the effect was not consistent, we went back to the data and said, we gave you the wrong data. We look at it, so the first day is when we protected the patient, then we have a flip. So lidocaine, what lidocaine could do? Well, lidocaine, I think that is an anti-inflammatory drug. We have a potential receptor that is targeted by local anesthetic, in this case, lidocaine. And as you see here, there is inhibition of the superoxide production. Patients do not come with more infection, or we don't see any indication that would have a very strong anti-inflammatory effect, but it does have a good effects on inflammation, I should say. So this is a study done in the ICU where patients were given a bolus of lidocaine followed by an infusion of 48 hours. And if you see here, this is one of the graphs, and there are other papers showing similar things. The numbers of rolling cells when they were stimulated with IL-8, with a pro-inflammatory cytokine, decrease here as you increase the concentration of lidocaine. And here you have a sort of the number of the migrating cell into sort of an endothelium assay, and you see here that lidocaine has this effect on rolling cells. Then we go to humans, and this is pretty robust effect. I've never had these standard errors or standard deviation in my lab, but people somehow has it. But you can see that lidocaine given IV is associated or cause significant reduction of IL-6 in these patients and IL-1. And then if you look at high mobility group box 1 protein, pretty much the same thing. So what is telling us this data is that, yeah, we have an anti-inflammatory effect. So we have an immune protective effect, we have an anti-inflammatory effect. What happened when people is using lidocaine to target specifically cancer cells? There's a lot of data out there. These are some of the papers, the newest papers in the last year or so, showing that lidocaine do have effect in a variety of cancer cells. Now, I have to tell you that these all in vitro studies. So you need to take with caution because sometimes the doses don't translate really well into the, what we see IV or epidural. So I have to cautious about that. But this is a very interesting study. This group from China, so they administered 30 milligrams per kilo of lidocaine, which is a fairly large dose to an animal. It's comparable to a human, yes, but we would be given a high dose in a human. So what they did is they administered lidocaine, and they co-administered then with cisplatin. There is data out there that local anesthetics do have some synergistic effect with some of the chemotherapy agents. So in this graphic, you can see that the days, the time after treatment, those animals treated with lidocaine plus cisplatin, as you see here, to have a lot better or suppression of of the tumors, and they didn't see any major toxicity, as you can see here, and here you have the tumor weight. So it works in this context, but I'm putting here because for us who works in cancer center, we have a unique opportunity to study this, that is in the high-PEC cases. High-PEC patients receive cisplatin or platinum-based therapies, and is the only time, I wouldn't say the only, it's one of the few opportunities when lidocaine could be given in the OR along with the chemotherapy. So I show you that lidocaine do have these effects. I don't know what's going on with lidocaine on stem cell. There is no data about that. And there is some data on epithelial mesenchymal transition, but it's not great. It's inferring from the signaling pathways that it blocks. But there is some data showing that blocks SRC, and SRC is involved in some tumors in epithelial mesenchymal transition. So we could assume, but the studies were not designed to test that hypothesis. So where we go from here? Well, I think we have a bunch of garbage data, mostly coming from the lab. The data from the lab I said it was garbage because it's very difficult to translate into human. It's the most difficult part that we all have. So, and then we have a bunch of cohort studies. What is the problem? There's been an explosion in retrospective studies. I love retrospective studies. I publish retrospective studies, but retrospective study has problem and keep my chairman very happy. So he sees my name and my colleagues' names there, happy man, I can live with that. But here they have the problems with big studies. Now, somebody said one day, hey, Juan, can we do a real world data? I said, well, we could look into this. The INFORM initiative by the FDA is pushing to do this, but this type of study take a lot of assumptions, a lot of AI, and when you talk to the folks who do artificial intelligence or deep learning, they all get stuck in the concept we have assumptions. So there is no causation, and if we have to take this as an anesthesiologist and provide or inform our patient, we need randomized controlled trials. But, so these are the problems with or the source of errors of the retrospective studies, as I told you. And then if we look at the different sources of where the error coming from the individual, from the technology, from the system, and it's plenty of bias. Now, but we can say that we propose a question, we do have a hypothesis, we collect the data, analyze the data, identify patterns to support on our hypothesis, and then publish the paper, keep your chairman happy, but we need to do the RCT. Why? It's the gold standard still. People is telling me, no, we need to do an alternative. Or in my opinion, we need to do the real experiment if we want to answer these questions. Now, RCTs have very big problems as well. It's expensive. Not every patient wants to consent. And then you have lack of external validity. If your RCT is going to be done in a major cancer center, we have to be sure that at least we are enrolling centers that we know that they have similar survival in our patients. Yes, we are going to randomize the patients, and they would have the similar chances to have one or the other. But if your cancer or if your center has poor survival, we have to be very sure with that. As I said, they are expensive. I had multiple problems. There is no much funding from a randomized controlled trial. I called NIH, and when I proposed a paper C, they won't control the whole thing. So it's very difficult to get funding from Australia and the NIH. The NIH wants to control the whole thing. So this is what we are stuck with. We have a disease state that is multifactorial, and most of our randomized controlled trials will target one specific intervention. That will translate to a very specific group of patients and not all our patients. Then we need to look at two important, in my opinion, outcomes: overall survival and quality of life. living miserable is not living for most of our patients. And the patients will not come and say, I have a recurrence here. The recurrence, we pick them up pretty much late because we have a schedule 3 months, 6 months. So for a patient is how I'm going to live, when I'm going to die. We have 3 studies that I know of, waiting for the results in breast cancer. We have a study that is recruiting in colorectal cancer in Romania, and the VAPOR-C study will have one of the 2x2 factorial design will have a lidocaine as a treatment. So where are we? Sometimes when I see this, I have this now in my office, I believe that I'm here, and we have a long way to go. I think we should be right here with our oncologist colleague. Thank you so much.
Thank you, everyone. I'd like to invite the panel up to the stage now and invite questions from the audience. But just to summarise before we begin, I think key take-home messages that we all would like to instil in you this morning are, first of all, that cancer is a big problem. It will touch lots of us personally and a lot of our patients in our practice moving forward. The cancer patient really is a distinct cohort with unique disease states that need particular consideration. I like Gregory's analogy of a fruit salad. The cancer is a fruit salad, the cancer patient is a fruit salad, and I think so too our approach to the cancer patient needs to be a multifaceted approach, which is difficult to institute and difficult to analyse, but is really what is essential if we want to improve patient outcomes. I hope we've also discussed how the relatively short time that we have with cancer patients can have a disproportionately large impact on long-term patient outcomes, and challenge you all to think about how you deliver anaesthetic care for your cancer patient. And finally, we've talked about the different areas of anaesthetic practice which have theoretical, biological and early preclinical and clinical data to suggest an impact on cancer outcomes, and also how we might approach future trials moving forward to really answer some of the big questions in onco-anesthesia. If anyone would like to come to the microphones for questions, that'd be great. Thanks.
It's easy.
Start?
Here's one, mate.
Someone's got to start. I'm Simon White. I'm a paediatric anaesthetist in Vancouver. So I came to this session, which on the face of it has nothing to do with paediatric anesthesia, but we spend a substantial amount of our time anesthetizing children with oncological diagnoses. And I wondered if anybody on the panel has anything to say about the relevance to any of this to pediatric oncology.
So yes, we published 2 papers already in HIPEC, and the setting of HIPEC in children. The data, of course, the data is a retrospective study. I cannot comment much on that, but it's very important. And I think in the IRA, the Anesthesia Analgesia journal will have in October or September is releasing a full volume specific for pediatrics. And we are publishing the evidence, so-called, on the impact of anesthetics and perioperative blood management in the pediatric population with cancer. But you are absolutely correct. Perhaps kids, particularly with leukemias, are much more exposed to anesthetics than any adults because they come very often for LP, ports, removal of a port, switching of a port, and unfortunately there is no data out there. Thank you.
Hi, Anushka Fonso from Memorial Sloan Kettering. Wonderful job, all of you. My question is to Professor Riedel. you had published a really wonderful survey looking at practice patterns in New Zealand and Australia. Have you noticed since then, and some of the data out there looking at TIVA and inhalation, a change in practice patterns since till now, or has it been stationary with the use of TIVA in general, real world?
Yes, so the question is, are practice patterns changing based on the retrospective
Yeah.
data? I think it's it depends on the institutional and bias within the institutions. So we, as a cancer center, we're starting to lose the equipoise. And if you speak to Tim Wigmore, they've lost the equipoise. And their clinicians are reluctant to, some of them say they won't recruit into the VAPOR-C study. And so, but the reality is there is equipoise in the literature, and we have to do this study prospectively randomized. But the institutions that are predominantly around cancer centers, I don't know about your institution, Sloan Kettering, but us at Peter Mac in Melbourne, the Marsden in London, there's a strong preference for TIVA at the moment. Can I ask anyone here, let's just get an audience, who prefers volatile or who prefers TIVA at the moment? So who's in favor of volatile anesthesia for cancer patients? Who uses volatile anesthesia for cancer patients? Yeah, so there's definitely equipoise there, and we need to study this.
I think one of the problems here as well is that, you know, the volatile propofol, we're not only getting it from an oncological standpoint, but like I said, I came from cardiac, and it's the exact opposite. So if you read the cardiac surgical or cardiac anesthesia literature, there's a term called ischemic preconditioning, where the volatile agents are beneficial for myocardial ischemia. And many of the anesthesiologists, like most of you in this room, probably do not practice in a specific cancer center. So you're hearing data coming from all sides, and that makes everything very confusing. And I think one of the problems as well is what Vijay said, that we actually need to have an onco-anesthesia society, which we don't have. So cardiac is, of course, 40 years ahead of us. They've always had societies, subspecialty societies, so they can bring their message easier to the practicing anesthesiologists than oncology. And that just muddies the water and makes everything more confusing.
If I can add to that, Greg, Landini published, about 2-3 weeks ago, New England Journal of Medicine, a large prospective randomized study in cardiac surgery. And in fact, the study was terminated early, if I read it correctly, because there was no difference in the cohorts, which helps us with the equipoise then. So, you know, if we have patients with cardiac disease coming for their cancer surgery, you would say, oh, we may have to use volatile, but in fact, they showed there's no difference in terms of ischemic preconditioning for patients having cardiac surgery. So there's no difference in outcome, volatile versus TIVA in cardiac surgery.
Just if I may add to that, we keep asking the question ourselves, why is it difficult for us to shift from a volatile-based techniques that most of us in this room were trained on and are comfortable with to move to TIVA? At least in the US practice, we don't have TCI pumps. And on our anesthetic machine, to have an end-tidal or exhaled agent concentration gives us some sense of comfort that we're able, that our patient is at least amnestic. Moving from that kind of a training and practice to totally a BIS or a PSA or a brainwave monitored guided TIVA is a big shift in our practice, and it takes a lot of vigilance, interest, and persistence to learn that technique. So in our practice, about 12% of all our anesthetics are TIVA, and the rest are still volatile-based. But not necessarily just to improve cancer outcomes. TIVA, if done well and safely in your hands, does have distinct other advantages. Again, we saw the evidence on anti-inflammatory effects of propofol, modulating the adrenergic stress response, opioid sparing, post-op nausea and vomiting, not as much disruption of the circadian and the sleep cycle and the sleep architecture in the post-operative period. Although this is all very preliminary and early evidence, just doing TIVA, if you can do it safely in your hands, again, has other distinct advantages.
Yeah, just adding to that, I highlighted to how our animal model, we've got this conflicting data, and we don't quite understand why. In Julia's hand, probably a fantastic anesthetic technique with TIVA, and then the other animal data is in the opposite direction. And so I think the best anesthetic at the moment is the anesthetic that you can do the safest with the least stress response. Yep. There's equipoise in the literature. We have to do this prospectively. And so, I wouldn't advocate that you go all switch from volatile to TIVA and then have patients that have a huge stress response. And it's the same with opiates. I think opiates play an important role in reducing stress response.
I hate to come up to the front like this. So I'm from Saskatchewan, and we are not a cancer center. We do everything. But there's been a real move in our department with some of the literature that is coming out to move towards using TIVA for cancer surgery. But I think if you're talking about some of the things that prevent people from doing that, one of them is just the conflict in the literature that's out there in terms of, and I think that's related to the types of cancer and which ones might benefit from that approach. Interestingly, we've had a move amongst the younger members of our department towards TIVA for environmental concerns. So there is a change of practice that's happening, and I think that for me, having grown up with the inhalationals, I find it a little bit, I don't feel comfortable with TIVA as much because I'm never certain about patient awareness, depth of anesthesia, and I'm not sure that some of these monitoring devices that we have really been shown to give us accurate measurements in the moment. And I think that that's something that really hinders someone. It'd really be nice to see more advancement in being able to titrate your TIVA anesthetic more accurately, and I think that that would have a large role to play in making people accept TIVA anesthetic.
Yeah, there's absolutely a learning curve to TIVA, but I've transitioned my practice, but I still strongly believe there's equipoise. The carbon footprint is a real issue, and I think we need to understand.
Luc de Baarmaker from Belgium. I have a question. We use a lot of patient-controlled epidural analgesia for abdominal oncological surgery. What would the panel advise for the duration of its use? 3 days, 5 days, 7 days? Any idea?
I could take a stab at that, but I'm sure, Vijay, you want to do?
Yeah, so it depends on what's the endpoint and what are you looking at. Are you looking at pain scores, opioid consumption, quality of recovery, the inflammatory immune responses, the complication rates, etc.?
Now, if assuming that there is a beneficial effect on cancer recurrence, so my endpoint would be reduction in cancer recurrence. So if we have patient-controlled epidural analgesia, 3 days, 5 days, 7 days?
All right, so I think it's an important, why does it work and what's the potential biological plausibility around it? We published a mechanistic study where we showed there was a reduction in lymphatic flow when you did a spinal anesthetic as opposed to general anesthetic. So the lymphatics are sympathetically innervated. That's the first thing. It may be the systemic absorption of the lidocaine and the amides that we give. That may be the other thing. And then retrospectively, one of our PhD students, Jonathan Hiller, published a retrospective review of esophagectomies. And it wasn't epidural, no epidural. It was a good functional epidural for at least 48 hours versus a epidural that needed rescue and it wasn't functional. And there was a survival difference. And what he did is he looked at the two groups by lymphovascular space infiltration as well, so trying to build in the cancer aggressiveness. And in both groups, there was statistically difference in terms of whether you had a good functional epidural or whether you had an epidural that didn't last the journey. So don't do epidurals at the risk of stress response. And it's the same in the vascular surgery literature. The occlusions occurred higher in the group that had poorly functioning neuroaxial technique. So, yeah, so if you're going to run it, I say 48 hours at least, but make sure it's a good functional epidural.
So, Juan, you want to comment on our inflammatory immune responses with epidural versus no epidural and the timing?
I be honest with you, there's no data out there to say put or not put an epidural, how long. We have no evidence that epidurals, not other blocks, improve or worsen the outcome of our patient. So if we believe in experiments in animals, we should believe in experiment in humans. And this is doing the RCT. Until I have no better evidence than an RCT, I will continue putting my epidural for a million things other than cancer recurrence. And we have to be careful, and I agree with Bernhard. A good functional epidural is the best, perhaps, for some patients we can give. But sometimes we do not know well how to manage the epidural. So it's not the epidural, or so it's not the violin, it's the violinist. If you have a patient hypotensive for a day because of an epidural, so I think, yeah, patient is 0 out of 10 of pain, but perhaps we're increasing the risk of myocardial injury in these patients. So we have to be very careful when we make these assumptions of whether we are going to improve or not with an epidural. From the inflammatory point of view, yes, it makes sense. But all these studies that we are doing, we are not correlating the inflammatory. We don't know the clinical relevance of a statistical significant in 10 picograms of a cytokine. We do not know. It is statistically significant, yes, clinically relevant. I don't know. So that's my advice, I would say. And if I show up in your hospital with occluded with a colon cancer, put an epidural. If you manage well, put an epidural. I have no problem with that.
I think that links in nicely with what do we do whilst we wait for the outcome of these large randomised controlled trials that try to answer these questions. And I think it really boils down to giving a good anaesthetic to minimise that adrenergic stress response and that immunosuppression. And how you achieve that is open to interpretation at this stage. I think it's also important to look at how we measure outcomes. So we are looking forward into long-term cancer recurrence and survival, but it's also easier and possible to measure short-term outcomes, such as postoperative complications, time to functional recovery, time to return to intended oncological therapy, and quality of life and patient-centred outcomes as well, which are equally relevant, important, and easy to measure right now.
If I can add one more thing, Julia, just Shamgar Ben Eliyahu published an interesting paper probably about a year ago. Breast cancer patients prospectively randomized to non-steroidals and beta blockers. And the beta blockers seem to have to be non-selective. It's probably the beta-2 receptor that plays an important role in oncologic outcomes. But interestingly, what they showed is it was mechanistic. They showed a reduction in expression profiles inside these tumors. So it influences the tumor microenvironment, the type of immune cells in there as well. So once again, supporting this notion of adrenergic inflammatory response.
I'd like to thank everyone for coming along today, and a very big thank you to all our speakers today, and I hope you found it informative and interesting.